talk. Now, I would like to move quickly, and I would like to invite Dr. Syed Abbas Raza. Sir, please join us for your presentation. Dr. Syed Abbas Raza has a fellowship from the American College of Endocrinology and American Certified in Endocrinology, Diabetes, Metabolism, and Internal Medicine. He is award-winning member of International Society of Endocrinology and Pakistan Endocrine Society, managing diabetes in the NASH.
Um, Thank you very much for the organizers for giving me opportunity to be in the company of the people I would love to be in company with. I have a disclaimer. I think before few years ago, I think general physicians and the medicine were taking care of diabetes and they were taking the ownership of diabetes. Time evolved and we got SGLT2. And then the field of endocrinology, diabetes, thank you, field of diabetes was kind of taken away partly from us as an endocrinologist because the SGLT2 showed data on SGLT, and the cardiologist started saying that diabetes is actually a field of cardiovascular disease. And I think the more you hear about the fatty liver disease, the more you realize that probably diabetes is going to be taken over from us by the gastroenterologist. So I have no disclaimer for this presentation, but honestly, this is just my attempt of getting involved with gastroenterology. So when you guys are taking care of diabetes, you will still remember me as an endocrinologist, that we were part of the whole ordeal. I think the liver-centric approach for multiple disorders, if you go back in history, and we have looked into it one time or the other, liver has been considered as the center of all the problems. Between the stomach and the liver, that has been the center of all the problems that we could treat. And that has been the ancient view, and till today, we are going back to the same point that we used to go back to. I tried to pull back some of and this is actually from my presentation about 15-20 years ago, first time when I was back in Pakistan, and I was asked to present on fatty liver disease in a gastrocon, and I was very happy because at that time, I was invited by a gastroenterologist. But I realized that the history of liver and being the center of diseases is not new. And I pulled out this ad from that era as well. There are also hot spring liver buttons which take care of the gastrointestinal problems. For me as an endocrinologist now, if you look at the diabetes world, all roads are leading towards Rome. And with that I mean, if you look at the liver, and if you look in association between the NASH and the comorbidities, it's related to obesity, type 2 diabetes, dyslipidemia, hypertension, and metabolic syndrome. And who is usually responsible as a specialist to take care of it? Endocrinology. So honestly, this is a relationship that we need to build over years, that somehow the core cause of the problem has to be dealt with in collaboration with the expert that we can see. So again, all these factors are related to it. So important part of any diabetes management is how do you deal with the causative agent as well as treat the reason and the side effects of it. I found this article very important. It's one of the groundbreaking studies that we actually, when you look at the cause of diabetes, I don't know if you had a chance to go through it. This was published recently in the journals, in which they looked at the fatty liver disease and its association with diabetes, and they tried to link with the fatty liver disease, the size of the fatty liver disease. But interesting point was, actually it's a combination of fatty liver disease with a smaller size pancreas. Big liver, small pancreas are actually a very good predictor for developing diabetes in the coming years. So if you want to strategize, if you want to put a patient-centric approach, probably that's one of the markers that we'll be looking at. If you have a fatty bigger liver and a smaller pancreas, probably that's something that you need to be worried about. Why do we need to worry about NASH? As an endocrinologist, why do I need to worry about it? If you look at the risk factors of it, again, all the risk factors that you count on are related to somehow metabolic disorders, which obviously somehow fall in our realm as well. So diabetes and metabolic disorder, NASH, I think it's coming to the same point. So treating diabetes in patient who has NASH. I'm going to talk about all the four spectrums of it, but let me just dissect that into two segments. First is the first, weight loss. And again, we have talked about the use of GLP-1, and again, I'm going to talk a little bit more about it. But just to give you a feel of what problem we are dealing with, in the Framingham studies and other studies as well, we have shown that if you're obese at the age of 40, you lose about 7 years of your life. If you're overweight, you lose about 3 to 4 years. And if you smoke and you're obese, then you lose much more than that. So that obesity is a major. And why is obesity, taking care of obesity, important? Because it's important both for liver disease, and this is the analogy that I would want to prove in the next 5-6 minutes, that weight loss affects everything in the metabolic world. So if you look on your left side, there are the beneficial effects of diabetes by the weight loss, and if you look on the right side, you'll see the beneficial effect of the weight loss in NASH and fatty liver disease. Something that we somehow tend to ignore. So if we are taking care of diabetes, if you look at the pure diabetes from the endocrine point of view, if you lose about 5%, you get better, you have a better result in hyperglycemia. You prevent diabetes if you lose about 10%, and there is a regression. Please remember the percentage here, because I'm going to connect this later on with some other facts as well. 15% weight loss, you can probably put diabetes into remission as well. If you look at the liver data, the same data will be presented, and obviously you will be seen throughout the meeting, in which the more weight you lose, the better it is for NASH resolution, fibrosis regression, steatosis improvement, and all the factors related to it. So, what are the medications we are using for weight loss? And again, it's not surprising that if you look at the top 1 or 2 or 3, they are purely weight loss medication. We see the beneficial effect of it. We see the beneficial effect of the weight loss medication, but obviously through the effects on the fatty liver disease and other things. But remember, the more weight you lose, the more chances of developing diabetes and other complications you get, lesser chances of developing that. But if you look at the bottom of it, now you're starting to see some of the medication that we use for diabetes, which have shown beneficial effect in weight loss, and on top of it, get the beneficial effect of diabetes as well. Why is that important? So probably this is not the last time you're hearing a talk from an endocrinologist on a medication which is used for diabetes, which has a beneficial effect on the fatty liver disease and the weight loss. And why do I say that? I don't know how many of you have seen the data and the wonderful data which we are seeing with the semaglutide in Wegovy brand, in which you use 2.2 milligram of the semaglutide, and you see about 10 to 15% weight reduction in these. It's a blockbuster. It's a diabetes medication which is showing effect on the weight loss. But it's not finished yet. If you look at the tirzepatide data, which is a GLP-1 and a GIP-1, actually the data is astonishing. You're getting almost the same results as if you had the bypass surgery done. The data is showing that you can get up to 20 to 25% weight reduction by a medication which actually we're using for diabetes. So again, the effect of diabetes on these medications, effect of these diabetes medication on weight loss, you'll be seeing more and more of them in the liver world as well, because they will have a beneficial effect on the fatty liver disease. Looking at why NASH is important when I'm treating diabetes, because if you look at diet perspective of it, there's a lot of things that we can see, and some of them were touched in the previous presentation too. Artificial sweeteners and their effect on the biotics of the microbiomes of the gut. Do they have a role? And we know that people who take a lot of sweeteners end up in more trouble than people who do not. And that has to do with the dysbiosis it creates in the gut. And this dysbiosis is not only shown to have a bad effect on the weight, it has shown the bad effect on the liver, and has shown the bad effect on the we will be actually considering twice now if we are using something which is a sweetener in our part of the world. Is liquid glucose, like fructose that we drink in it. The reason I'm presenting this is that for a diabetes, what would you say when you're talking about diet? Don't take too much sugar. What they do end up doing? They start taking more of the sweeteners. What if they stop? If we stop them from taking sweets too much, which is in the solid form, what they do end up doing? They start taking sweets which are hidden in the form of juices and whatnot. And we know that the fructose and other liquidy sugary drinks cause more trouble sometimes than, and there's a multiple mechanism which is beyond the scope of this meeting. So next half of it, let's talk about the other approaches of it. Now, I'll give one medication at a time. This is the whole list of medication that we are using in diabetes world. But if again, when we are selecting a medication for diabetes, for me, when I look at someone's ultrasound in diabetes, if it doesn't show fatty liver disease, I have to actually look twice if it actually missing. Because most of the people in the diabetes world have a fatty liver disease, and I think the data internationally shows a little bit less of representation of Asian population, because I think our fat, and again, there's a lot of new information also now based on the famines which affected this part of the world and how those famines in the past have resulted in our capability of storing everything in our gut in the form of fat, leading to diabetes and metabolic process. And I think fatty liver disease is much more common in our diabetes world as compared to anyone. But interestingly, if you look at all the medication that you see on the on this slide, you see the positive effect on the fatty liver disease. Most of them are related to the weight loss as well, except for the fact that two actually outliers. One is pioglitazone, which actually doesn't cause weight loss, but again may cause but still have a beneficial effect. And metformin, I would have expected more positive data, but unfortunately we don't have that robust. We do have data, but it's not that robust if we look at it. So SGLT2 came into existence, and we've seen that the SGLT2, empagliflozin, you use them, you get a better control in diabetes, but you get better marker, you get better ALT control in these individuals. And sometimes it's very important to see that response, because when you're treating someone with diabetes, these people are automatically on statins, these people are already on other medication which can affect. To see the liver function test going down, it's always a pleasure to see this. And this is the same study. In the E-Lift also, we saw the beneficial effect of empagliflozin, and then there's a whole list of it. GLP-1 is a drug or the medication in its own class. We have it in injectable form, we have that in oral form. They work in multiple different ways. And I've shown you some of the information as far as the GLP-1 semaglutide data is concerned, and some of the effect of the GLP-1 and GIP-1 agonist as well. Just to give you one of the studies, and I'm not going to spend too much time here as well, is improvement or no change. If you just focus yourself on the blue and the gray area of it, if you look at if you use of semaglutide and change in the fibrosis stage, changes in the steatosis, changes in the lobular inflammation, as well as hepatocyte burning, all of them show that if you're using GLP-1 in this set of population, you see the beneficial effect of that in probably NASH, in the fatty liver disease, and in the composition of it. So diabetes world is filled with a lot of excitement, because now we have certain things, because if I remember 2003, 2004, what did we had? We had sulfonylureas, we had TZDs which were getting into trouble, and then we had metformin, and then the DPP-4 came in. So there was nothing much exciting. Diabetes world now is very exciting because there's so much happening. There's so many new medications that we're treating with. TZDs, actually, the first data which came out was troglitazone. We all know how it turned out because of certain side effects. It has to be pulled out. But again, if you look at the pioglitazone data, it definitely has a beneficial effect of it. Is pioglitazone going to come back with a full swing in treatment of diabetes? I'm not sure. But I know in most of the diabetes centers across, some of the experts have started putting pioglitazone in the treatment of diabetes, because somehow the scare of pioglitazone and the TZDs was overblown out of proportion. And again, I do understand there is complications of these things that increase in the weight, pedal edema, CHF high risk. But again, there is definitely some side of TZDs which we might need to see in one form or the other. So you might see some comeback of TZDs, which we are already seeing in the lower doses of these medications. One of the things that again that we are always dealing with, what are the medications when we're treating someone with diabetes in the condition when they have advanced liver disease. All the medication could be used initially as far as diabetes management is concerned. Metformin and insulin is probably the safest if you have advanced liver disease. But again, medications like GLP-1, SGLT2, and probably pioglitazone in lower doses can be used safely in the initial phase, and in the later phase you can only use insulin and metformin. But in between, these medication can play a major role in probably reversing some of the problems, probably getting the medication slightly, and getting your patients on their feet and with a better control of diabetes based on the data that we have till now. Important component in the when you're treating someone with diabetes, there are a few things that you need to use in certain conditions, and I'll show you some of the vitamins which might be considered more commonly by us than any other subspecialty when we're treating diabetes. Number one, vitamin E. Vitamin E definitely has some role in fatty liver disease and NASH and improvement of symptoms. And I've shown you data with the pioglitazone and vitamin E. The only problem is the use of vitamin E in a diabetic patient cannot be promoted because of the cross reactivity, the complication that we see more common with a patient with diabetes than in common population. So again, vitamin is not the front line or recommended dose. Can we use it for shorter durations? Yes. But would we get the beneficial effect of vitamin E in a diabetic patient in a lower line? Probably not something that I would promote using it for a long-term basis in it. So again, this vitamin is something which is helpful, but unfortunately, when it comes to the endocrine world, we cannot use it for too long. Interesting data, again, I'm not sure if this is something has passed through your eyes, is something with vitamin D and homocysteine levels and the causative effects of vitamin D and homocysteine. Interestingly, vitamin B is very commonly used in diabetes work because our first line treatment is metformin. Metformin is something that we use as a gold standard. Metformin can lead to vitamin B deficiency. So as a standard, I would usually replace vitamin B in our patient for a short duration and then maybe take them off or check their level and then. My usual practice is I usually replace it for certain time and then stop it and then replace it again instead of checking levels every time and making sure, because it's a very cheaper remedy. The getting a test is a difficult thing, but if you use it for short duration, I don't think it has any harm in it. So vitamin B and homocysteine has some cause and effect on the fatty liver disease if you can take. So another attempt in getting close to the gastroenterologist esteem group. If you look at, this is probably the last slide, management of diabetes and the fatty liver disease in this time, I think the overlap of medication is so huge. I remember the time when I would get a call from Dr. Shahryar asking me to start someone, the cardiologist doctor, the famous cardiologist Dr. Shahryar, asking me to start medication for diabetes, which will help heart, because that initially the SGLT2 were new and GLP-1 were new. And again, obviously, the reason for starting those medications was diabetes. And again, that was needed from my side to help them treat it. Now I don't get a call from them. All the cardiologists are starting SGLT2 in diabetes or not with diabetes. So there goes my 50% of the patient. I used to get a call from Dr. Altaf Alam and Dr. Arif Nawaz about starting someone on something for diabetes. There goes my next 50% practice, because probably you guys will be taking care of it. Please remember me whenever you need. So I think it's more of an integrated approach that we should all be using. Fatty liver disease will end up getting the limelight in the next 5 to 10 years. Honestly, in the endocrine, I'm pretty sure that the fatty liver disease will get a limelight in next few years. And again, the beneficial effect of it will be taken from it. With that, I thank you all for your attention.
Very nice talk. So we have